Hello everyone, this is Mary Gregory with MAS Coding Solution. Well, it's been a time since we've been together. I am so glad to be back with you all today. Today we are going to be talking about documentation. We're going to talk about compliant documentation. Documentation is kind of near and dear to my heart because you cannot do great coding without great documentation. But you know what? Coders are not responsible for the documentation. Physicians are. Or anyone that is a qualified healthcare provider that is licensed to make a diagnosis. So let's talk a little bit about diagnosis coding. First of all, you have to know you got to have a source. You got to have a source. What is the source? Where can you go to get this information? So naturally in coding, it's the patient EHR, medical record, or EMR. That is our source for getting the, the information that we need to code accurately. The source for coding and reporting diagnosis, like I said, is the medical record. Now, you have to learn, especially if you did. Well, let's talk a little bit about patient type. So, medical records, everybody gonna have one. When someone show up at the facility, at a physician office, you gonna generate some type of record on that patient. So you can have an inpatient record, you can have an outpatient surgery record, you can have a physician office record, you can have an emergency department record. You can have what we call outpatient diagnostic records. That's when people come in just to get a lab done or they just get a radiology done. Now, each record will have certain information that must be the same. But then you're going to have records that are going to have different information depending on what the patient type is. Now, you always got to have demographics on everybody's record. Demographics mean you're going to have a patient name, you are going to have their date of birth, you're going to have addresses, you might have social, and today in our healthcare environment, they take fingerprints sometimes, they may do your retina, but you got to have a source document, which is your medical record. So a physician office record will not look the same as an inpatient record at the hospital. But you still have to have those demographics. An ER record or emergency department record is not going to have everything that an inpatient record has. An outpatient surgery record is not going to have everything that an inpatient have or a physician office have. So I just wanted to get that straight. So I may talk to you all a little bit in a very broad sense about these records. When I am coding an inpatient record, I have to use the entire medical record to code from. But I have to learn how to do that because you cannot spend all day in a record. So for inpatient coders, we know it's critical that we look at the H&P. It's critical that we look at progress notes. Physician orders, not so critical because a lot of the information that we need to code from may not be in those orders. We cannot code from nurses' notes. Depending on my patient diagnosis and what's going on with the patient, I might look at the nutritional notes. If the patient have maybe some type of wound, I may look at wound care notes. But it all goes back to the type of patient I have. When I'm doing ER or ED coding, I know I got to look at the physician notes. See, and then I can maybe go to the treatment plans to make sure I'm not missing a diagnosis or missing some type of procedure that may have been done that the physician forgot to document. All those things are important, okay? So I wanted to talk to y'all about that. So in order for my documentation to be compliant, I have to make sure that those notes are signed off by the physician. They have to be authenticated. Whether you're using paper or EHR or hybrid, those notes have to be authenticated. We have the Medicare condition of participation that tell us certain things that has to be done, especially in an inpatient setting. You have some Joint Commission guidelines that lay things out for us too. The physicians have, usually the State Medical Association that give out guidelines as to what they should have in their record as well. So we're kind of talking about just the basics of getting your documentation and making sure it is compliant. Coders can only code from physician documentation or anyone that is qualified, a healthcare provider that is qualified to make a diagnosis. There's a lot of people that can make a diagnosis, but that don't mean that they qualify. When we talk about qualified, we're talking about mid-level providers. We're talking about physician assistants. We're talking about nurse practitioners. We're talking about midwives, nurse midwives, or advanced nurse practitioner. We're talking about those kind of people. A nurse may write a diagnosis, but a nurse is not legally accountable for making a diagnosis unless they are in your state. Let me put it like that. I can go to the physical therapy note and I can get a diagnosis off of that therapy note, but guess what? That therapist didn't make that diagnosis. The physician did. When that physician sends someone to physical therapy or occupational therapy, he or she must tell them what is the diagnosis, and then they will base their treatment plan around that diagnosis. Okay? So I just wanted to mention that. Why sometimes our documentation is not good. You know, when the documentation is ambiguous, when that documentation failed to reflect that provider intent or the impact, then we may not have compliant or quality documentation. So we have to train and help our physician to understand that the documentation and the coding is telling a story about their patient. And we want to tell an accurate story about their patient. We also must realize that this document, our codes now, are being used to do studies on and to improve health care. And if that documentation is bad or ambiguous, then we're not going to have good data, people. We're just not. Why do we have poor documentation? You know why we, some of these, they said these are some of the reasons why we have poor documentation. Number one, I think this is changing. You know, when a person is training to be a doctor, there is so much they have to learn that sometimes it's only after they have graduated, they've been through the residency program, and they're ready to go out and practice that somebody said, oh, by the way, let me teach you what you need to document when you begin to see patients. Or, you know, as a resident, I used to love to get the resident note, because as a resident or as a medical student, they will write these beautiful notes. Well, when you get out and start seeing patients, maybe you don't have that amount of time to put in. And so good clinical documentation have not been taught in the past, but I think we're seeing that change. For an inpatient setting, we have so much information to look through. So that's why sometimes it's a little bit more complex in the inpatient setting. Of course, in the inpatient setting, we may have patients that stay longer, have multiple physicians, like hospitalists. We'll have a hospitalist. This is what I've noticed. A hospitalist A will maybe admit the patient and see that patient for 5 days. Well, then their shift is up, and now you got a different hospitalist B coming in, And he started talking and writing notes about from the day he began to see the patient. So now you got these 5 days of note that nobody have brought forward to incorporate, so you can continue to tell the story. Now I'm on YouTube, so I'm out here on YouTube, and I'm gonna make the statement: the EHR, the electronic health record, has not helped this situation. It's still a lot of cutting and pasting and drop down box and macros and templates, and sometimes doctors just don't tell a good story like they used to when they had to handwrite notes. You know, in the old days when they used to have to handwrite a note, if somebody came in with a GI bleed, they would actually describe what that blood looked like. They said, oh, it's a bright red blood, or it's a dark red blood. The patients had a cup full of blood that they spit up. They don't do that now. They just come in and say the patient got a GI bleed, and then eventually they'll tell you it's lower or upper, but they don't really describe it anymore like they used to, and I think that's a shame. They said that we don't have consistency in how we record and collect information. There's no consistency there, so that's a problem. But we need to work on improving our quality of information that's in the patient chart. And remember now, on the HIPAA, I think it's HIPAA, the patient can see their chart. I don't know if that's a good thing or a bad thing. You know me, I'm always just honest with you. Sometimes you can see a chart, and if you don't know what you're reading or understanding what you're reading, then you may have a tendency to think, oh my God, they didn't treat me correctly or whatever. And then if the information is so disjointed, like the information is in the EHR, is so disjointed. There's one particular, there's an EHR out there, and maybe the physician just used it wrong, I don't know. But they bring that patient history. If they've seen that patient for 10 years, guess what they do? Copy and paste everything that have happened to that patient from 10 years ago into the current record. Does that information really add any benefit? A lot of times, no. You know, I don't need to know that the patient had dermatitis when they were 16 years old. They 26 now. They 30 now. They no longer have no problem with dermatitis. And so sometimes there's so much useless information in an EHR. So I know I'm probably going to get in trouble. People are going to think I'm talking about the EHR. I'm not. I'm just stating that's the way it is. There's a lot of useless information in an EHR now because of how the physician is being trained, what's going on with their training. But we need quality documentation. We need to be able to tell the insurance the story. We need that if that chart go to court, can that chart be defended in a court of law? Sometimes the documentation is so bad that it cannot be. And now in our world, we're getting a lot of denials for very specific types of diagnoses. I don't necessarily think all those denials are appropriate, but because the documentation is so bad, they're taking money back. But we need the quality documentation. We need to recognize and realize that the documentation is regulated. You know, like I said, Medicare had the condition of participation, and it tells us what we should have in a record. You know, Joint Commission tell us what we should have in a record. Even CMS, Medicare get in on it. They said, look, if you're going to take somebody to surgery, and I think I'm correct on this, I don't really do that part of medical records anymore, but if you're going to take somebody to surgery, you should have a H&P within 7 days. You know, if you seem to pay, you may have scheduled a surgery 2 weeks ago, 14 days ago, especially now in this COVID climate. You know, it's very hard to get a surgery done now because of COVID. So they may schedule you out 14 weeks. Not 14 weeks, 2 weeks, 3 weeks. But guess what? When you come in, somebody need to update that H&P and says heart and lungs clear, respiratory great, or there's been no changes since the last time this patient was seen. Somebody need to do that. See? So we need the physician to understand we are not trying to be a nuisance to them. We're just really trying to make sure that their information can stand up in a court of law. But now I do believe we do have physician death by query. Sometimes we ask way too many questions to a physician rather than going out, doing the research, and knowing that certain things we may not have to query the physician about. We need to learn how to interpret that information so that we do not need to query about. So some things we need, this video not going to go into details about the quality documentation that we need. The next video will. This is just part 1 talking about quality documentation. So always remember, you want your health record to be complete and legible. You want your patient to have a good history where they are documenting past and present diagnosis. Are there any risk factors involved with the patient? And that could come from the patient's past family social history. And this is from a long, long time ago. And I don't know if we really do this now or not, and maybe we should. If not documented, the rationale for ordering any type of diagnostic test or lab can be easily understood why. And I think physicians really document like this, where they say, okay, the patient need, I don't know, a creatinine BUN done. But they may not write that they think the patient is dehydrated. They may not write that they think the patient got CKD. Somewhere in that chart they may have written it. But when they write the order for the lab, they may not rewrite that. And that's what I'm talking about. So, but somewhere in that chart, I as a coder can figure out why that test was done. And I may not always need to query the physician. We cannot query the physician for every little thing or every little abnormality that's out there. You know, I'm a person that runs a low hemoglobin. I just do. So they don't need to run a lot of tests on me because that's my natural state. And so that, you know, if he says in the H&P, Miss Gregory generally run a low hemoglobin, 10 is normal for her, then he don't need to order no test. He already said why. It's inferred as to why he's not going to order a test. He might say, you know, Miss Gregory's having a cough and a fever. I'm going to order a chest x-ray. That's inferred. Now you know why he's ordering a chest x-ray. The patient may or may not have pneumonia. The patient may or may not have congestive heart failure. But he has inferred in that documentation, he or she has inferred why they're doing it. And also the physician should always document what type of response is the patient having to treatment. And sometimes these EHR, guess what? They will say something like, patient being treated with IV antibiotic. Next day, patient being treated with IV antibiotic. Third day, patient being treated with IV antibiotic. Fourth day, patient being treated. Did they ever get better with the IV antibiotics? Did they ever improve? See, they don't write that kind of stuff. They just keep cutting and pasting. And we don't want to do that. And so we're talking about having, quality documentation. And this is part 1 about quality documentation. So always remember, you want your documentation to be able to tell the story, stand the test of time, and can hold up if it's ever legally challenged. And so you got to make sure certain things are in that chart. If somebody go to the ED, that ED doc need to document accurately. Now, he's not going to document the same way if you at a physician office because you're in the emergency department. And so things going to be done differently. And we as coders have to realize that. Well, this is going to end my presentation for today. I want to thank you all for being here for part 1 for quality documentation. We will be doing part 2 for quality documentation. And this can help you on your CPC exam. This kind of information can help you on your CCS exam or any certification you're trying to do. I do also want to announce to you that in November and December of this year, we will be doing our final 2 prep classes for this year. We will be doing the CPC review on November the November the 13th and 14th, and we'll be doing December on December the 11th and 12th. Come, let us help you get prepared for that CPC review. I have a card here. I decided I'm going to start reading some of my testimonies. She said, "Dear Mary Gregory, I just found out I passed my CPC certification today. I am so grateful for the excellent video series you did covering chapter by chapter CPC prep. It really helped develop my critical thinking skills and taught me how to use my code books to the fullest. I would not have been half as prepared without the videos." Thank you so much for that testimony. And I look forward to hearing from the rest of you all that have passed the CPC test based on taking our CPC review. Remember to follow us on Facebook and LinkedIn and Twitter, and always go to the website. We are doing some great things there, elevating some things and becoming a much better organization just for you. Talk to you later.